Good evening and welcome you to this AIOC course. And this is about the challenges of cataract surgery in coexisting retinal diseases and uveitis. This is IC146. We have very, uh, very excellent a group of speakers here, and they are all very good teachers as well. And they will they will discuss about the pearls of managing these challenging situations. And the topics we will cover today are cataract surgery in patients with diabetic macular edema. I'll be talking about that in a short while. And next, Dr. Ajay Pal will be speaking on cataract surgery in patients with pre-existing uveitis. Then cataract surgery in patients with proliferative diabetic retinopathy will be dealt with Dr. Aniruddha Maiti. Thereafter, Dr. Arup Kumar Bose will talk to us about cataract surgery in patients with AMD. Thereafter, cataract surgery in patients with pre-existing retinal diseases, peripheral retinal degenerations will be covered by Dr. Krishnendu Nundi, and the last topic will be cataract surgery in vitrectomized eyes by Dr. Arup Bhomik. So we will try to keep our talk as brief and short as possible. And as our chairman scientific committee has just told us that we need to finish early. So I think we will straight away go to my topic, and that is the first topic. But there may be a slight alteration in the seriality, as we have seen the sequence of talks, because some of our speakers are already engaged in other halls at the same time, so they will come. Okay, so let us start with the first talk, and I'll be talking now on cataract surgery in patients with diabetic macular edema. Well, I have no financial interests or disclosures to make in relation to this presentation. Here, cataract, we all know, is an important cause of visual impairment in diabetics. And as we all know that the incidence of cataract surgery in diabetics is 2 to 5 times higher than a comparable non-diabetic population. And we have to discuss during this 8 minutes are the guidelines. We will see there are many guidelines, we'll talk about what the guidelines have to say. Then we will talk about the progression of DME after cataract surgery, management of DME after cataract surgery, and effect of cataract surgery on DME. So these are the few topics we're going to talk. Well, as for the guidelines, as you can see, that there are many guidelines, both international and national guidelines are available. And, all these guidelines kind of want to take care of the local needs and local problems. But principally, these guidelines tell us the same principles of management. So let us look at the principles of management. For mild cataract, careful assessment of the diabetic retinopathy status should be done. And patients without vision loss, with a very clear fundus view, may not require cataract surgery at all. And when we look at the patients with moderate cataract, there should be an attempt to treat any severe NPDR and PDR with laser PRP, and any DME with focal or grid laser or anti-VEGF therapy before cataract surgery. So by moderate cataracts, we mean this kind of cataracts where fundus view is available, but detail is not seen, but we can obtain a fairly good view from the OCT. And these are the patients who needs to be treated for the diabetic macular edema and the diabetic retinopathy prior to cataract surgery. But for very severe to advanced cataract, like this kind of cataract, with poor fundus view, if diabetic retinopathy status cannot be assessed adequately, we need to consider cataract surgery early, followed by assessment and treatment as is necessary. So now basically the gist is, if diabetic macular edema is present, consider anti-VEGF therapy or steroid therapy before surgery, at the time of surgery, or either it can be done before or at the time of surgery, or after surgery if DME is discovered when the medium is cleared, like the last kind of advanced cataracts we have shown. Now let us look at the progression of diabetic macular edema after cataract surgery. If we look at the natural history of macular edema after cataract surgery in diabetics, we will find that clinically significant macular edema arising after surgery commonly resolves, particularly if retinopathy is mild. Now, poor visual outcomes after cataract surgery are very strongly associated with the duration of diabetes and the preoperative status of diabetic retinopathy. And vision loss is mostly due to diabetic macular edema. Now, cataract, we all know cataract surgery worsens macular edema and hastens the progression of diabetic retinopathy. The same has been shown in the ETDRS reports as well. Now, it is crucial to know the risks of worsening of diabetic macular edema with cataract surgery. And if we look at the protocol Q of DRCR network, we will find that patients with non-center involving DME which doesn't involve the center, had a chance of 10% of developing center-involved DME after cataract surgery. And those patients who had existing center-involved diabetic macular edema had a 12% chance of worsening of DME. And the history of treatment of DME puts the patient at the greatest risk of worsening of DME at the time of cataract surgery. And the risk is about 20%. 20% of those patients who has a prior history of treatment of DME will show worsening of DME after cataract surgery. Now, this is again a very interesting publication from UK Diabetic Retinopathy EMR user group, and they have shown the risk of macular edema associated with preoperative rates of diabetic retinopathy. And the risk of DME in the first year postoperatively was about 1%, even when there was no diabetic retinopathy preoperatively. So even in patients who did not have diabetic retinopathy preoperatively, they run a risk of about 1% of developing diabetic macular edema post-cataract surgery after 1 year. So within 1 year post-operatively. And the worst risks are with severe NPDR, and they have a risk of about 13.1% of worsening of DME. Now, how do you manage DME after cataract surgery? We need to look into the perioperative and operative considerations in diabetes. And amongst the preoperative conditions, as we have discussed, if visibility permits, so we need to assess the level of diabetic retinopathy and presence of DME, and we need to treat DME and DR both before cataract surgery. And use of non-steroidal anti-inflammatory drugs before surgery is recommended very strongly, because we know that blood-retinal barrier is already disrupted in diabetic retinopathy cases, and over and above, a high amount of inflammation that occurs due to cataract surgery will even jeopardize that. It will affect further the blood-retinal barrier in these patients. So it is recommended that we use NSAIDs before surgery. Well, as for the perioperative and operative considerations, phacoemulsification is the method of choice. And these patients are prone to have small pupil, anterior capsular contraction, and higher rates of PCR. So we need to be alert and be more vigilant for this kind of, when we operate on these kind of patients. And as for the choice of intraocular lenses, a large optic hydrophobic acrylic IOL is the IOL of choice. And we do not recommend any multifocal or EDOF IOLs in these patients. Well, we know that phacoemulsification has been proved with many publications that it is the best method for cataract surgery in these patients. And post-operatively, we need to use steroids and NSAIDs for a longer duration. And dilated fundoscopy is recommended post-operatively 1 week, 4 to 6 weeks, and 3 to 4 months following cataract surgery to keep looking at the macula and the retina as such for DME or other DR changes. And as for the treatment, to address post-operative DME, a combination of phacoemulsification with any other adjuvant treatment is recommended. It could be intravitreal anti-VEGFs, steroids, or laser photocoagulation as the case demands. And there are many drugs available now. But timing is everything when planning for cataract surgery in patients. In patients who have already been receiving monthly anti-VEGF injections for DME treatment, we need to plan cataract surgery midway between two injections. And sometimes we need to differentiate between DME and pseudophakic CME, and fundus fluorescein angiogram would be typically the gold standard for that, where we would find optic disc staining or hot disc with typical petalloid pooling of the dye in pseudophakic CME cases. Also now automated algorithms are available with OCT to differentiate both. Now the effect of cataract surgery on DME in vitrectomized eyes, it has been proven now that previous vitrectomy does not appear to lessen the rates of post-cataract surgery macular edema. Well, to summarize, pre-existing DME prior to cataract surgery or history of previous treatment of DME may increase the chances of DME after cataract surgery. Assessment and treatment of DME prior to cataract surgery is a must, and treatment of DME with intravitreal anti-VEGF steroids and lasers have shown promising results. Thank you. If there are questions we can take now or maybe at the end of the session, may I now invite our next speaker, Dr. Ajay Pal, who really doesn't need any introduction, to come forward with his topic. And he is going to talk about cataract surgery in patients with pre-existing uveitis. Over to Dr. Pal, please.
Thank you, Siddhartha. It was a pleasure to have me here, and I'm really honored that I'll be speaking this session as cataract surgery in patients with pre-existing uveitis. I have no financial interest, whatever I show. But the pre-operative evaluation and the complete evaluation is ophthalmic evaluation is what you need. Look for glaucoma, CME, retinal neovascularization, poor visualization if you see the posterior segment. If you cannot see, obviously you need to do a OCT or a B-scan ultrasonography and a systemic examination and laboratory evaluation. Definitely need to do that. Indication for surgery in uveitis is post-uveitis is usually visually significant cataract, as would be in any other cases. Cataract precluding any posterior segment evaluation, that's also needed, and any phacoantigenic uveitis. So pre-operative control is must. A quiescence period of 3 months is preferred. A multidisciplinary approach is to be done. Topical, systemic, corticosteroid, immunomodulator, whatever way, you just make the eye quiet. And look for adverse effects. Visual prognosis depends on basically presence of pre and post-surgical inflammation, quality and efficiency of surgery, and of course, management of complications. How to prepare for surgery? Steroid responders. I mean, you must have given steroid pre-operatively to control the inflammation. So if you see that in pre-op steroid regime may be modified in this sort of cases, intravitreal triamcinolone, dexamethasone before or during surgery, you take a decision on based on whether CME is active or history, there is a heavy flare or high risk of flare-up. And IV methylprednisolone 1 gram again would depend on to replace the pre-op oral or post-op oral therapy. You can do that steroid regimen. Well, ECC versus SICS. Well, definitely there is increased incidence of clinically significant inflammation requiring treatment, and phacoemulsification remains the surgery of choice because of the decreased incidence of clinically significant inflammation, decreased CME and epiretinal membrane, decreased surgical time, minimal tissue handling. This is all known to us. Pars-plana vitrectomy may be required in cases where uveitis is associated with vitreous opacity, and these are the two studies which course there is definite improvement, 72.2 to 63.2%, and most the different cause of word vision is due to CME or glaucoma, secondary glaucoma. Intraocular lens, we know you should avoid ACIOLs, sulcus fixation IOL, silicone IOLs, IOL with polypropylene haptics. IOL implantation is less than 2 years of age, well, it's something to be careful. Well, definite preference is PC IOL in the bag and acrylic IOLs heparin coated. Well, there are studies to suggest that even hydrophilic acrylic IOLs, but definitely acrylic IOLs are the IOLs of choices. This is the study by AIOC2021. The acrylic IOL, there's definitely less inflammation. And then again, there is a hydrophobic plus hydrophilic IOL. The PCO seems to be more with the hydrophilic IOLs and definitely better UVL compatibility, the study says. So let's come to this small surgical clip. Well, this is a cataract, which is, you can see it's dense cataract. At the same time, there's a fibrotic capsule. So what we are doing is trying to extend the pupillary area. See this two Uglan soup. This is the fibrosis. So I put in hooks there in this case, and the hooks definitely give me the enough size. Look at this, how fibrotic it is. It can be very difficult in this sort of cases. You have given steroid, you have given immunomodulators before surgery, maybe you have given even or intravitreal, or just after the surgery, you can add intravitreal, either triamcinolone or Macula. See, we are using scissors to cut that capsule. And sorry, this is gone there. And once this is there, see, I'm using scissors. Well, and then many times you have to be very careful that you don't pull on the zonules. Zonules can come off in this sort of cases. So be careful, do the emulsification. Normally they are softish cataract because this is a secondary cataract. It's not a senile type, but then emulsification is done. And then in this case, as we finish up the case, we are putting in a hydrophilic IOL. As you can see, this is a hydrophilic IOL. This patient did very well. This was done almost 7 or 8 years back, and I'm using hooks there, and the hooks are removed at the end of surgery. Most of the time, the hooks can end up in disfiguring your this pupillary margin. So that's why those pupillary expanders are come. But this is another case where this, you can see this is also in a bad case, bad condition. See, so I'm trying to look for a area where I can puncture that area. I'm using forceps, and there I'm blunt dissecting, taking out that membrane out. Taking that membrane out. See, there it is. I'm using scissors also at some point of time, and then once this is done, well, I a little bit of dilatation, manual dilatation. That's what I do, manual stretching, and then once that is done, I do prefer into using, in this case, a BX. Our friend is there who has invented that, and this comes really handy in this case. As you can see, I put in yes, CBX goes. I get a dilatation around 5.5 millimeter. Basically, you don't get much more than that. And then this is a soft cataract. I just go in and remove the cataract. And then in this case, I prefer to put in a hydrophobic IOL. Hydrophobic IOL, as I said, that they do acrylic hydrophobic IOL. Go and get the visco from behind and above the lens, try to remove as much to lower as much chance of inflammation, because this is inflammation prone, and then put visco in front of the lens, and then remove the lens there, and trying to remove that. And then at the end of the surgery, I'm just trying to get that back to shape using the IA here, and that's how that gives definitely a good result. And I put in it, as you can see at the end of the surgery. Here you can see at the end of the surgery what the inflammation is on here. I put a intravitreal triamcinolone. So post-operative inflammation, pre-operative control. This will depend on how you control the inflammation pre-operative. Minimal or intraoperative tissue handling in the back placement of IOL, NSAIDs, and topical or periocular steroids as may be deemed necessary, and intravitreal triamcinolone. One have to be careful of the IOP rise also. So this is the different uveitis, and the folks in heterochromate iris shows better prognosis, 80% having more vision. GIAs can be very difficult patients because higher incidence of membrane formation. Behçet's disease also does good, so does toxoplasma. There might be recurrence. Eye implantation is not recommended in GIA. Basically, sarcoidosis, good visual outcome, multifocal choroidal. Also, it might chorioretinitis after within 6 months it might return. CME is very high, 21 to 50%. So lesser with well-controlled uveitis and oral corticosteroid, and a recurrent one can lead to permanent visual loss. And this is the study. CME, well, as I said, intravitreal triamcinolone can be tried. Fluocinolone I have not tried, but I have tried with dexamethasone. Definitely good result. PCO is also incidence is very high, 23 to 96%, and that will be pigment deposits. As I said, juvenile infective arthritis can be very bad. Inflammatory membranes forms, and they are very difficult to manage. So IL is not recommended in this patient because you get IL dislocation will also be reported because of the fibrosis that sets in later on. You can have posterior synechiae, chronic uveitis, IL entrapment, anterior capsular phimosis, shrinkage, and all. So these can be controlled by giving adequate amount of steroid right from the beginning. Lens cell proliferation, cyclic membrane can lead to phthisis. So in conclusion, young patients typically at work or study, complex problem, high expectation, prolonged management course, but don't be hurried for the surgery. Waiting for and preparing for the correct time makes the difference between good and long-term result and blindness too. So control inflammation first, and definitely an experienced surgeon is better equipped to handle these cases than the surgeons. So the take-home message is diagnostic evaluation of uveitis, pre-operative control, immunomodulator drugs, and careful surgery and selection of head forms the mainstay. And there's a few studies. This is a study from Shankar Netala, Dr. JB and Dr. Virendra, which says the pre-operative and post-operative inflammation of modern day surgical techniques are definitely better. The intraocular lens designs that are there. And this is another surgery decision making when you do so pre-operative corticosteroid prophylaxis, and in patients less than 2 years of age, the eye where inflammation is poorly controlled, intraocular lens should be deferred. This is the Dr. Chi, now their study from Singapore. And with proper patient selection, improved surgical technique, optimized pre and post-operative care, patient innovative can have a good result. And this is again intravitreal dexamethasone implant study, which is a randomized trial, definitely has shown better result. Then this is a study by Dr. Agai Vasauda and team. And this is the guideline for immunosuppressive drugs in patients with ocular inflammation. This is a big guideline there. You can see the anti-metabolized T cell inhibitors and alkylating agents for all everything. And just last, not the least, this is the IGO study. Again, Dr. Chi, decision making. And so patient must be monitored closely. This is very important. Once you've done this surgery, don't forget about it. Let the patient come back and monitor it. Thank you. Thank you for your patient hearing.
Thank you, Dr. Pal. That was wonderful. All the full of wonderful parts as usual, wonderful surgeries, lot of take-home messages. We will take the questions. If there are any questions, we can always take now, but I think because...
Siddharth, Siddharth, can I ask?
Yeah, please.
Dr. Pal, how long does it take for the blood aqueous barrier to stabilize after a cataract surgery in a uveitic patient? Number one. And is there any role of injecting sub-tenons triamcinolone at operation after the surgery to control post-operative uveitis on a long-term basis?
See, the blood aqueous barrier can be as long as 3 months. This, the breakdown of blood, 4 to 6 weeks is the normal. In the uveitis, I take it normally in the uveitis patient, which I have done. This earlier, I used to give a lot of PST, posterior subtenon. This was in the ECCIL days, around 20 years back or 15 years back. Give a PST, but many patients did come back with the intractable glaucoma. The removing that becomes so. This is where I control the inflammation, and then many times I've given just 1 milligram of triamcinolone intravitreal. I think that clears up fast. Within 2 or 3 weeks, it disappears, and IOP rises definitely better control. But then always, Pred 40 is my drug of choice, and I normally keep it up to as long as 3 months. Okay. And put an NSAID also. Even if I stop it at 2.5 months, but keep the NSAIDs up to 3 months.
That's important till the blood aqueous barrier stabilizes, isn't it? Okay.
Very important point brought about. Thank you, Arudha, for that. I think if you have more questions, you can go ahead, or should I call upon the next speaker? Yeah, the next speaker is Dr. Aniruddha Maiti. Welcome. You can please start sharing your screen, and he's going to talk about cataract surgery in patients with proliferative diabetic retinopathy. Over to Dr. Maiti.
Thank you, Siddhartha. Is my presentation visible?
Yes.
Well, I will be speaking on the preferred practice pattern in cataract with PDR. Well, as we all know that diabetic patients are 2 to 5 times more likely to develop cataract, and that too at an earlier age. And significant number of those patients undergoing cataract surgeries are actually diabetics. So it is very important for early recognition and treatment of diabetic retinopathy before doing the cataract surgery, which actually influences the final visual outcome. Now, we're aware of this advanced diabetic eye disease, that is fractional RD, persistent vitreous hemorrhage, or a neovascular glaucoma. This all conditions can be associated with the cataract. Now, a proper planning is very important. We might line up into 5 scenarios. The first scenario is a cataract with a PDR. Second is a cataract, already the vitreous hemorrhage has happened. The third scenario is a cataract with a tractional retinal detachment. Fourth scenario is cataract with neovascular glaucoma. And the last one is a cataract with no visibility. Diabetic macular edema has been excluded and it's already been taken care by Dr. Ghosh in the earlier presentation. So coming to the first scenario, cataract with PDR, when the visibility permits, we have to administer the pan-retinal photocoagulation. But if the lens opacity precludes a preoperative PRP, it can be administered as an indirect PRP immediately or within 1 week of cataract surgery. Uncomplicated phacoemulsification generally does not lead to diabetic retinopathy progression. And if it does, it is mainly due to the poor glycemic control. Now, this is an example where the quiescent retina after PRP and cataract surgery can recover up to 6 vision as well. So coming to the second scenario, that is cataract with vitreous hemorrhage, the B scan is very important. We need to rule out tractional retinal detachment. The combined, if there is a tractional retinal detachment, we have to take care of the tractional component as well. And presence of pre-existing PRP scars associated with a better outcomes. And now coming to the preoperative use of injection Avastin, it has been proved that it actually results in rapid regression of the retinal neovascularization as early as 24 hours. And there are several small retrospective series reports which says that it might have a role. But DRCR.net protocol AN actually showed that when compared with anti-VEGF versus intravitreal saline, it actually showed no difference. So there are certain surgical pearls. We should be very cautious in lifting the posterior hyaloid membranes, which is actually 100 times more adhered compared to the in normal cases. Intraoperative bleeding is a concern. We need to increase the infusion pressure, and endocauterization is a must. With the wide field viewing system, what we need to do, we need to ablate the retina up till the ora to prevent the rebleeding. And when cataract limits the visualization, obviously we need to plan a combined surgery. But the cautious, the risk for the combined surgery is if there is a severe PDR, it increases the risk of NVI and NVG. So these are the third scenario where the cataract with the tractional retinal detachment, it might be an extrafoveal or it might involve the fovea. As we know that a TRD, if it is there for 6 months, it might be associated with photoreceptor damage, broader areas of adhesion. There is a chance of membrane reproliferation. So the vitreous should be dissected as far as possible. We can observe the extramacular TRD, and silicone oil as opposed to long-acting castoprone decreases the incidence of recurrent bleeding. So most of the cases in the bad TRDs, we prefer to use oil over gases. But the recent advances of the viscodissection, curve scissors, segmentation, and delamination gives a more predictable results in these bad cases as well. Combined surgery has an advantage of faster recovery, better post-op visualization of the retina. As I already mentioned, it is associated with 4 times higher incidence of NVG. So in high-risk eyes, cataract can be performed later if it is possible. We can do the TRD and later on plan the cataract. And obviously, here there is a role of pre-op intravitreal Avastin, and preferably it is given within 1 week of injection. Many prefers 3 to 4 days. And few reports suggest that if you use anti-VEGF in a bad severe TRD cases, which might actually result in crush syndrome, which is the worsening of the TRD due to anti-VEGF. This is one of the case which is a favorable outcome after the surgery, combined surgery. And there's another scenario which is the cataract with NVI, prognostically not a great case. Prompt treatment with PRP induces regression of the new vessels from the before the cataract surgery. We can use the anti-VEGF either intercamerally or intravitreal, which actually causes the dramatic regression of the neovascularization. phaco with or without trab and vitrectomy should be considered at earliest once the NVI regresses to enable the treatment of the posterior segment pathology. However, the visual outcome following the phaco in this eyes with NVGs are usually poor. Trab with antibiotomolites or any drainage shunt, generally the results, the success rates are bad. Combining phaco with endoscopic diet laser photocoagulation is the last option. So to conclude, the number of people with the diabetes is definitely increasing. So is the cataract. The diabetic patient with visually significant cataract pose a unique challenge during the surgery. However, with careful pre-treatment of the diabetic retinopathy and minimally invasive surgical techniques, the visual recovery is mostly quite good. But most important part is the patient education about the prognosis and the results of the surgery. Thank you.
Thank you, Dr. Maiti. That was really wonderful. And if we have any questions, because Dr. Maiti has to leave for the other session.
Yeah, I've got a question. Dr. Maiti, if a patient has got cataract with proliferative changes in the retina, should an anterior-segment surgeon deal with it or refer it to you?
So the thing is, if the visibility permits the treatment of the posterior segment, I think that should be addressed first before proceeding with the cataract surgery.
Okay.
Just a query.
That means anterior-segment surgeons can take up.
Of course, they can take up. Along with the posterior segment surgeon standing as the. I just had a question. Now, you are giving intracameral, by rule, by general rule, would you like to do a combined TRD, PTR with a cataract surgery, or would do the retina and then do the cataract if that is visible?
There is two situations where actually
if it is visible, if the retina is visible.
If the retina is visible, we will go ahead with the retinal, we will address the retinal pathology first, the diabetic retinopathy, address it, and then later on go ahead with the cataract surgery. And if the situation is that NVI is there, then we will give the intercameral, regress the NVI, and then go ahead with the surgery. And depending on the grade of the cataract surgery, whether the combined surgery will be planned or not, it depends on the visibility.
Doctors, with all due respect, can we please wind up this session over here, because we have another session which is supposed to go on till 5:55, but also we have to close the halls at 5:25 because we have the inauguration ceremony.
Just a minute. The program that has been circulated says that this program is from 4:30 to 5:55. How can you mess up? Half of the speakers have talked and half did not.
Sir, it is the message from the organizing committee.
No, but I have just talked to the chairman scientific committee. He said we'll wind up by 5:30.
5:30. That's what. 5:30. 5:30.
It's only 5 now.
I'm saying that we need the discussions that we are taking. Instead of that, we can invite the next speaker.
We have half an hour time. So we have got two speakers.
We are before time, actually.
Sure, sir.
We are before time.
It was just a reminder, sir.
Yeah, I understand.
Siddhartha, I am in.
Yeah.
Thank you so much, doctors. I would leave it up to you. Please continue.
We will welcome our next speaker, Dr. Arup Kumar Bose. Arup, could you please start? And Dr. Homik will speak next.
Okay, let me share screen first. Yeah.
I will take a leave.
Sure. Thank you so much for being.
Am I visible?
Yeah. You're visible, you're audible.
Yes. Okay. Thank you very much. Thanks, Dr. Siddharth, for giving me this opportunity. I'm going to talk about cataract surgery in patients with AMD. I'm going to finish fast because everybody's in a hurry. Anyways, the challenges that we normally face is unanswered questions which are there in AMD. What is the risk of progression after cataract surgery? Will there be any benefit after cataract surgery? When should I operate? And again, the grading of cataract and AMD in relation to the visual function and manage the visual prognosis and the patient's outcome. This is actually very important. We all know that the cataract surgery causes inflammation, number one, intraocular pressure fluctuation changes, which causes changes inside the eye, and it causes change in the blood-retinal barrier as such. So, and it can actually cause decompensation of the fragile choroidal vessels that have taken place due to ARMD, and it can also cause further leakage and hemorrhage. So if you look at the articles that show that, excuse me please, yeah, which shows that cataract surgery is a risk factor for AMD. There are three big articles which are studied 7,664 patients in the Beverdam study, which is quite old in 1998, Blue Mountain study again in 1998, and Rotterdam study, which is in 2008. All of them had shown that there is progression of AMD after cataract surgery. In the first study, Beverdam study, there has been an increase in incidence by 11.5% and progression by 3.8% in a huge population. And the Blue Mountain study showed incidence of AMD in 7.6% of pseudophakic and aphakic patients, and as compared to 2.1% in phakic patients. And Rotterdam study also has shown there's an increased risk of geographical atrophy. But these studies were done during the most, when SICS is to be the surgery of choice for cataract surgery, and probably injection anti-VEGF was not available. Then came the studies which showed that cataract surgery is not a risk factor for AMD, and these include age-related eye disease study, which came out in 2006, which showed that there's little evidence of progression to wet AMD or geographical atrophy after cataract surgery. And then the age-related eye disease studies 2, which studies 1232 patients in 2012, which shows that there is actually an improvement in vision in patients with AMD if they're properly treated, and they've shown that there are plus 10.4 letters improvement after cataract surgery. So a review analysis of lot of studies that took place, and it had come out in 2014, has shown that cataract surgery actually benefits the patient in AMD. And the two very well-known study, Anchor and Marina trials, have also shown that cataract surgery appeared to be safe and beneficial for all eyes with AMD, including ranibizumab-treated eyes with neovascular AMD. But, a big but, a study, it's a meta-analysis which came out in September 2020, last year, September, from China. It's a big study where they studied more than 3,500 patients, and they have shown that Asians are more likely to develop AMD after surgery, and Asians and Caucasians differ in AMD genetic structure. So we need to understand this, and they have shown that there is a positive correlation between cataract surgery and progression of AMD. Now coming to the IOL selection, as we all know, AMD affects visual acuity and contrast sensitivity, and hence we need an IOL which has got a brighter light to retina, lesser glare, and lower light scatter, and hence aspheric, monofocal, and toric lenses are accepted because they provide better contrast and less glare. Multifocal IOLs are not recommended because they are known to cause reduced contrast sensitivity, but a big question mark comes whether we should use a blue blocking intraocular lens or not, because the benefits they give are they reduce the transmission of 430 nanometer light, which is a harmful light, to by 50%, and reduces the cell death by 80% as per the study Sparrows and colleagues in JCRS 2004. It also causes reduction in geographical atrophy, and that is also came out in a study in 2015. But the problem is patients with AMD are already suffering from reduced scotopic sensitivity, and these lenses are known to reduce the scotopic sensitivity by 14 to 21% as per this particular study. And rod cell population and sensitivity reduced with age and also AMD, and these patients have worst contrast sensitivity and blue-yellow foveal sensitivity. So we really actually do not know whether to use these lenses in patients with AMD or not. Now coming to a few words about the visual prosthetic IOL devices that are used. this implantable miniature telescope, which was approved by FDA in 2010. It is for monoocular implantation. They enlarge the retinal image by 2 to 3 times. They're good. Only problem is they're too thick like this, and they lie so close to cornea. There's enough chances that the patient might get corneal endothelial loss. Another lens which was very popular, which came out from Optolite Vision in Israel, it's basically a mirror telescope which can be implanted even in pseudophakic eyes as a piggyback lens, and they produce retinal enlargement, and they are actually very good because they cause improvement in vision by about 20 to 30%. Then there's another IOL VIP lens, which is a dual concept wherein you put in a high minus lens in the bag and a high plus convex lens in the anterior chamber. And this also gives a magnification of 2 to 3 times. This is how it looks. There are 2 lenses. It can be done in a single surgery, but again, the risk of endothelial damage because of the anteriorly placed ACIOL. This particular lens, AMD lenses, this is a Galilean telescopic lenses, which is basically a prismatic lens, which deviates the light that is falling into the retina, has become popular, and it's also available in India nowadays. And they can cause an increase in best corrected visual acuity by 67% and near vision by 50% if the patient is chosen properly. This is the Indian version of this lens. I've got an experience of using these lenses in 3-4 patients till now. What actually it does is, instead of focusing the light onto the fovea, it takes up a point which is 7 to 10 degrees off the fovea. These are called preferential retinal locus. And hence, if the patient has got a healthy retina at an axis of 7 to 10 degrees, patient is going to get a better vision. This is a patient. KC Das is basically a cultivator. That's my first this sort of AMD lens implanted. As you can see, the right eye has got a large geographical atrophy, and hence nothing could help this particular patient. In the left eye, the atrophy is confined to the center, and this patient had a pre-operative vision of 6/36. Cataract was not that much, but still I ventured to put in this particular lens. And as you can see, the distant vision improved from 6/636 to 6/12, and the near vision improved from N36 to N/8 corrected, and the patient was actually very happy. And if we undercorrect these eyes with +3 diopter and put in an extra spec of +3 diopter for reading, this patient will get a extra magnification of 1.5 to 2 times. That's again beneficial for the patient. This is another patient. It's not a case of ARMD, so I'm not discussing. So coming to the timing of surgery in relation to VEGF therapy, there's again a bit of controversy. We all know that the aqueous half-life of bevacizumab is 9.8 days within the eye. Ranibizumab is 2 hours within the eye. Brolucizumab is 4.5 days. And hence, if we inject these agents during operation, there is a risk of dilution of the medication. It can affect wound healing and even can cause wound dehiscence. It can increase the inflammatory response. So as per the study which came out in 2011, anti-VEGF should be given 1 to 2 weeks before phaco, and that is safe and effective in cases of AMD. So to conclude, the key points are, it's a tricky situation and it needs additional consideration. Good preoperative examination and assessment is pivotal. Extra preoperative chair time with the patient and party is required. We need to aim at least traumatic surgery and a good perioperative medication, and plan and discussion about the disease and proper timing and course of anti-VEGF injection that might be required are to be properly discussed. Thank you very much. Thank you for the patient hearing.
Thank you so much, doctor, for finishing on time.
That was excellent. And we will take up I know it is a wonderful presentation, a lot of points to take, but since we don't have time to discuss, let us call upon Dr. Arup Bhome for his presentation next.
I think my topic is already discussed by another speakers. I think.
That was PDR, but
Okay, my topic is cataract surgery in vitreous eye. Thank you, Siddhartha, having me in this course. I have no financial interest to disclose. Difficulties is basically absent of vitreous support. So there may be a deep AC or fluctuation of AC. So nuclear sclerosis, most of the case present with the nuclear sclerosis cataract, if the patient, the most of the patient after VR surgery, if they do not gain so much of vision, they are basically least interested of that eye. And they generally delay the surgery. Unfortunately, when they come to us, then it is a very hard cataract. This can be happen patient with very hard cataract with deep AC and capsular junular problem. So it may be happen during the removal of vitreous rays, and very rarely. Nowadays it is rare, but previously there is a postcapsular injury. So what are the combination? So it is a hard cataract, maybe it is a hard cataract, it is a deep AC, it is a capsular junular problem, and maybe there may be the capsular injury. So all kind of difficult situation can happen in post-VR surgery. So to be frank, nowadays we are not seeing any such problem in all the cases, because most of the minimum cataract up to grade 3 actually managed by the all retinal surgeon. They don't send to us for the cataract surgery. When they generally send to us for the cataract surgery, they have either they have at least 2 to 3 problem with this. So the key to success is the slow motion phaco. If you have a active fluids, you can keep your irrigation pressure very low. If you other machine, you can lower the bottle height, and the key is a tight wound. So this is a case is of post VR surgery. I can just show the fluctuation of AC. Once there is a fluctuation of AC, you can see again it is come down. AC is come down, and in between the surgery, now it is absolutely come down. In the almost very difficult to do the phacoemulsification, but otherwise this cataract is not difficult. And so only there is a lot of fluctuation of AC during the surgery. Just see this when I just put the irrigation again, there is a deep AC. So these can be happen. This is actually features of lens iris diaphragm retropulsion syndrome, which where it is happens where there is a laxity of jonule. So this absent of vitreous suppose with the laxity of jonule, that LRDS syndrome can be accentuated in case of post-vitreous eye. So one should be very careful during the surgery, because in hard cataract with the very deep AC fluctuating is very difficult to manage. So this is a case, this is a normal case. I don't think this is a very difficult case. And this is a post-VR surgery sent to me and planned for the surgery. And the nucleus is a little hard, around grade 4. And as it is a post-VR surgery, I expecting a lot of us. You can see my parameter. I keep my irrigation pressure is only 20. And this is a beauty of the machine. You can do the surgery a low parameter, and I am going relatively slow during my manipulation, all the manipulation. So nothing great about this surgery, nothing new. So you can maintain your irrigation pressure low or bottle height low and go as usual. And don't venture direct chop. It is better to debulk the center and proceed for the small chop, because it can, if you go for the direct chop, it can create more jonular problem. This is a case, this is other eye patient has a anophthalmic. and the patient undergone the retinal detachment surgery, and the retinal surgeon told me that this patient has before operation has a 6/9 vision, and you should put a implant a IOL, and it is really difficult in case of this subluxation. This type of cases very hard, colomomatous eye, anytime rexis can yeah. So I keep my finger crossed and started my surgery. I managed the rexis very well. You know that even you maintain the rexis in coloboma, there is a zonular problem in this area, subluxated area, that from there that rexis can extend. So I always put two hook, never put this area, though the subluxation area is here most. I never put any hook in the this area, because there is an inherent problem of the zonular in this area. Better to put the two iris hook, a capsular hook in this. Always avoid the iris hook in case of subluxation, in case of coloboma. Here I am not holding the hook capsule margin. Here I am just holding the iris pupillary margin to hold the case. Somehow this patient, you can see there is a lot of hard cataract. I am able to do the big rexis without any extension. I am doing sub chopping in these cases, and ultimately it is managed. And you can see that the last piece, you even Siddhartha, the last previous IC we have discussed, there's a lot of viscoelastic is sometimes is thermogenic. I know there is a thermogenic, lot of viscoelastic like viscot. If you put repeated viscot, there is a chance of wound burn, because the viscot can clog this wound but even this, I just put lot of viscoelastic. I never mind to have a wound burn to rather rupture the PC in this particular case. So you can see this is you can then see this that catch the iris. So if you think it is better to put a CTR before removing the last quadrant. So somehow I put the CTR and implanting the lens in the sulcus eye bag. This is a case I just show you. This is a case I just started post-via surgery almost 5 years back. The patient does not regain vision after surgery, so generally he led the surgery. When it came to us, it is no paper, previous paper was available, and I'm going slow in this case. And it is a dictum on my surgery, no hydrodissection in hard cataract post-via, and going slow. I am doing the chopping after central debulking, and I am able to crack the nucleus and make a quadrant comfortably. And whenever I try to remove one quadrant from the bag and to create more space in the bag, so that I can subsequent chopping is facilitated, then I see that the large PC rent. Actually, there is a large PC rent, and that there is no vitreous support, so I thought it will shrink. So I immediately put a lot of viscoelastic and did the optic capture and continue my phaco. Thank you. I think I finished my talk on time.
Yeah, thank you so much, Dr. Bhomik. That was marvelous. Lot of learning points as usual. There are a lot of things to discuss, but because of want of time, let us finish the presentation. May I invite Dr. Bindu Nandi next? Please start your presentation. And after everything finishes, if we have time, we can discuss a little.
It is 5:20. I don't think we have time.
5:30.
Thank you, Dr. Siddhartha Ghosh, for inviting me in his IC. So I'll be talking about, after such a lovely videos by Dr. Arubda. So I'll be talking on a blunt topic, cataract surgery in peripheral retinal degeneration. So I have no financial interest. So let us see what are the degeneration we often face in our day-to-day practice. Is the lattice degeneration, the horseshoe tear, operculated hole, and atrophic hole, whenever you see in a retinal periphery. So let us see if case scenarios. First is 27-year-old female, both eye myopic, -6 diopter spherical power, multiple lattice degeneration as you can see at the periphery. There is no symptom. The patient wants LASIK surgery. What to do? Second case is 32-year-old male with a cortical cataract. Myopia is -7. Vision is 6/36. A single lattice degeneration in both eyes at supratemporal quadrant with a hole. What will be the next step? Now the case 3 is a 67-year-old male with -7 diopter spherical power. Other eye lost due to retinal detachment, complaining of decrease in vision in the right eye due to cataract, and there is a lattice degeneration with a hole at the infratemporal quadrant, and the patient wants cataract surgery. So what are the evidence? What are the evidence shows? The first evidence I'm showing is a case control study, which shows there is a definitely lattice degeneration has a role to play, and the retinal detachment in the fellow eye has very high significant rate of retinal detachment on the operating eye. Next is the axial length, elongation of the axial length. More the axial length, more chance of retinal detachment after cataract surgery. Now, though we practice doing laser to the prophylactic laser to the peripheral retinal degeneration, even though the retinal detachment can happen in 2.1 to 8.8%. So the major review says, even though we have done the prophylactic laser treatment, the patient should be under follow-up because retinal detachment can happen even after successful laser therapy. So evidence says eyes with a lattice degeneration with or without hole more likely to develop retinal detachment after refractive surgery. But 80% of retinal detachment are not associated with the pre-existing retinal degeneration like lattice. So the Folk et al. Has done a study in 1989, long back. So they have treated, they have observed the 151 patient, treated fully 164 patient, and partially treated for lattice degeneration of 73 patient. So what they have seen, the fully treated eye with a lattice degeneration, other eye is being retinal detachment, the patient has less chance of developing retinal detachment in the laser treated eye. So they have concluded that fellow phakic eye, other eye having retinal detachment, if you found lattice, we have to do with the laser. We have to go ahead with the laser, and the fellow eye before or after refractive surgery. If you found lattice degeneration or any peripheral degeneration, we have to go ahead with the laser therapy. So as per the recommendation by American Academy of Ophthalmology, HST, the horseshoe tear should be lasered always, dialysis should be lasered always, operculated tear sometimes, atrophic hole rarely, lattice degeneration rarely. So we have to weigh the risk-benefit ratio always. Now, counseling of the patient is important if the patient complains of increase in floaters, change in symptoms, or carton coming in front of the eye. We have to see the patient with intraophthalmic probe. So, take-home message: HST and lattice in a symptomatic patient or fellow eye retinal detachment, we have to go ahead with the laser. HST lattice in a symptomatic patient with a family history of retinal detachment, laser to be done.
Sorry to interrupt, but the buzzer says that we need to wind up the meeting.
This is the last slide. Please
Yes, sir. Yes, sir. We can wait for a minute. We can wait for a minute.
Purnesh, let the presentation get over.
Thank you. I am stopping. here.
Thank you so much, sir.
Thank
It
you,
is
Dr.
very
Nandi.
kind of you to sum up within the time.
Wonderful presentation.
We
We were not allowed to discuss anything in this session, but anyway, thank you. I think I would like to thank everyone. Dr. Ajay Pal, Dr. Arup Kumar Biswas, Dr. Arup Bhomik, Dr. Arunodha Maiti, and Dr. Krishnanandi for being with us during this program, although they all had programs parallelly. Thank you so much. And since we are forced to stop here, we cannot take more questions or discussion.
Thank you so much, sir. And we are very, very sorry for creating this hindrance.
Thank you.